Good morning. My name is Rationale Miles, and I want to welcome you to the NIH Office of Disease Prevention's Medicine Mind the Gap seminar series. This seminar series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods in prevention research and to support the development of better methods. Before we begin, I have some housekeeping items. To participate by Twitter, follow us at NIHPrevents and submit questions using the hashtag NIHMTG. You may also email questions to prevention@mail.nih.gov. There is also a link to a feedback form at the bottom of the videocast page where you can submit questions during the talk. At the conclusion of today's talk, we will open the floor to questions that have been submitted via Twitter and email. Lastly, we would appreciate your feedback about today's seminar. Following today's talk, please visit the ODP website at prevention.nih.gov/mind-the-gap and click the link to the seminar evaluation under the resources section. Your insights will help us continue to improve this seminar series. At this time, I'd like to turn things over to Dr. Carrie Klabunde, Senior Advisor for Disease Prevention here in the Office of Disease Prevention.
Thank you, Rationale. Today's the first installment in a three-part Mind the Gap series of sessions on disease prevention and screening. Dr. David Ransohoff will be presenting on making guidelines for colon cancer screening, evidence, policy, and politics. Later this fall, sessions on guidelines for screening in children and defining and measuring overdiagnosis will be presented. Dr. David Ransohoff is Professor of Medicine and Epidemiology at the University of North Carolina at Chapel Hill. He has written extensively about how to improve research methods for evaluating diagnostic tests with seminal publications in major journals. His academic degrees are from Harvard University and Case Western Reserve University. He trained in gastroenterology at the University of Chicago and completed a fellowship in the Clinical Scholars Program at Yale University. Dr. Ransohoff was one of the first clinical epidemiologists in the subspecialty field and has published extensively on colon cancer screening, including articles about colonoscopy, fecal occult blood testing, sigmoidoscopy, CT colonography, and stool-based DNA testing. He's also written articles about clinical practice guidelines and screening policy. His papers about methods for evaluating molecular markers for cancer screening have been published in Science, Nature Reviews Cancer, and the Journal of the National Cancer Institute. One of his overarching concerns and interests is with the quality of the guidelines development process and the relationships among evidence, guidelines, and patient outcomes. Dr. Ransohoff has spent most of his career at UNC Chapel Hill, where he has directed the Robert Wood Johnson Clinical Scholars Program and the NIH-funded K-30 Faculty Development Program to help junior faculty develop careers in clinical and translational research. It's my pleasure to welcome Dr. David Ransohoff and turn the session over to him.
All right. Well, thank you, Carrie, and good morning, everybody in cyberspace. The topic today is making guidelines for colon cancer screening, evidence, policy, and politics. And the goals of the talk are to discuss with you and to illustrate the relationship between science, or gathering evidence, good quality evidence about screening's ability to discriminate, change outcomes, policy, how you go from science to policy or guidelines about practice, and politics, and how that may relate to these other things. And the overarching theme is that guidelines don't just emerge from evidence in some kind of passive way. Guidelines are a very human product, and their quality varies. And the importance of guidelines and understanding this process and optimizing it, which is one of the charges of our profession, the importance is that guidelines affect patient outcome through clinical practice. And they affect outcome because they provide targets for what we as clinicians are supposed to do. They may be related to reimbursement. They may be related to other quality measures. So guidelines provide very important targets, and we need to understand where they come from and whether we can rely on them. I think that guidelines making is one of the highest callings of our profession. How do we go from science, which we do, to policy, which eventually translates to outcomes? caveat for today is that this subject is really, really big. This talk is about 40 minutes. There will be time for questions. The topics here are selected. We're necessarily going to be at a high level in many ways for this talk. We're going to drill down in a number of selected areas, but there's lots of things that we don't have time to talk about. If Carrie and Rationale give me time, we may be able to continue this for a 24-hour session sometime. But it's a really big topic, and we can't cover everything. The organization of the talk is I'm going to provide two parallel histories. First, of evidence-based medicine, because this is the basis for the science. And the field of evidence-based medicine has grown up in the last 30 or 40 years and is very closely related to guidelines making. And then I'm going to talk about the history of colon cancer screening science, what we've known about it in the past, policy over time, politics, and we're going to end up with some challenges for this field, mainly about the process of guidelines making, also about colon cancer screening in 2016. So let's start with a brief history of evidence-based medicine. The definition of it is the conscientious, explicit, and judicious use of current best evidence in making decisions about the individual patient related to outcome, decisions that maximize or affect the outcome, benefit versus harm for the individual patient. And it uses the best available clinical evidence from systematic research as put forward by David Sackett, who was a founder of the field of clinical epidemiology, established a department at McMaster, went on to Oxford. And he wrote this in the BMJ in 1996. The field had been alive for about 20 or 25 years by the time he wrote this particular article. Let's think about why was evidence-based medicine developed in the first place, because this really relates to some of the challenges that have evolved over time and that we're going to be facing today. Preventive medicine was in the 50s and 60s. It goes back that far. It was assumed to be good. Prevention is better than cure, an ounce of prevention, and so forth. And this assumption of good was challenged by clinicians and clinical epidemiologists like Dave Sackett, who asked, how do we decide whether a preventive intervention is appropriate to do, and is it possible that a prevention effort could cause net harm? And the kind of thing that Dave Sackett and others looked at in an article in the New England Journal, and they did lots of neat stuff from McMaster, was they looked at what happens if we label people with hypertension. Will a problem be caused in them missing work? And they did a randomized controlled trial at a steel plant in Canada where they took people with mild hypertension that was not affecting their health. They labeled they told some of them, you've got mild hypertension. The others, they didn't. And they saw that over the course of roughly about a year, that there was a higher absentee rate from work for people who were labeled as hypertension. Hypertension wasn't causing any problems medically, but because they got labeled, there was a downside. And they looked at other kinds of harms that prevention can cause. And they said, gee, if we're doing screening for hypertension and we can't really treat it, or we can't treat it and lead to a better outcome, maybe there's a downside. We sort of have to think about harms as well as benefits. And from that kind of questioning by Dave Sackett and others in the UK and Canada, and then the United States, the Preventive Services Task Force, now formed about almost 30 years ago, formulated questions to decide when is it appropriate to screen. And the kinds of criteria that they developed were, is the burden of disease high enough to be concerned about? If it's untreated, does disease lead to a bad outcome? Does screening and treatment, the intervention, reduce that bad outcome? We need to know, is there an intervention that works? And then what's the benefit? What's the balance quantitatively regarding the outcome of benefit versus harm? And the task force then developed rules of evidence related to these ideas. And in this hierarchy, clinical trial evidence was preferred because it's unbiased, it's a way of understanding cause and effect, and that was where they started. And the task force, when it started, applied these questions to preventive measures, starting with the annual physical exam. What they did was this was their first task. They deconstructed the yearly physical exam. What about taking a blood pressure every year? What about a cardiogram, a chest x-ray, tonometry, a glucose tolerance test? What about all of these things that we do and we've assumed are good? Should we do them? And the result was, when they deconstructed all of these individual parts, most of them disappeared. They were no longer supported by the U.S. Preventive Services Task Force, the American College of Physicians, the AMA, and a lot of them just dropped by the wayside. The assumption that a yearly physical exam was a good thing. And what happened was that the task force had established a process, rules of evidence about how to evaluate how decisions affect outcome. In this case, decisions about prevention, it could apply to anything. And how do we look at benefit versus harm? Now, the process that the task force developed, and it's widely regarded as a leader, if not the leader, this is very detailed, it's time-consuming, it's expensive, hundreds of thousands of dollars. It can now take well over a year to formulate questions, assemble evidence, do a systematic review that has its own rules of how you do it, develop recommendations, get external review published, and so forth. It's a very big deal. And the product, one of the products is a hierarchy of recommendations, which I'm not going to read in detail at all, but just tell you very briefly about that there are grades of recommendations. A means recommends strongly, B means recommends without strongly, C is makes no recommendation for or against, D recommends against, and I says insufficient. And the only point that I want to make, it's not the details here, but you see where all these arrows are. The U.S. Preventive Services Task Force found good evidence, benefits, substantially outweigh. All of these words are defined very explicitly. And Russ Harris, in a very nice article now 15 years ago, outlined what these rules of evidence were and what the process was. And it's sort of an operating manual in great detail. The task force sort of obsesses over these words because it's trying to be very explicit, have rules of evidence stated in advance, and to try to understand and describe what they are doing. This is a major strength of what the task force has done. So with that background, just roughly about the field of evidence-based medicine, why it was created, where it came from, let's now talk about how colon cancer screening, science, policy or guidelines, and politics have also evolved over that period of time, coming up eventually to the challenges in 2016. In the beginning, before 1996, the guidelines for average risk people for screening, no organizations had made formal recommendations about fecal occult blood testing, sigmoidoscopy by itself, the two combined fecal occult blood testing and colonoscopy. Before 1996, the recommendations were very variable and just not heeded. In the beginning, there were few guidelines or guidelines makers. And then evidence began to emerge. Here's evidence of efficacy, fecal occult blood test, stool blood test, clinical trials. Guaiac-based fecal occult blood test screening reduces colon cancer mortality, is found in a clinical trial by 33% using every year rehydrated guaiac-based fecal occult blood testing in a study funded by the NCI and NIDDK in the U.S. And by 15 to 18% using every other year non-rehydrated guaiac-based fecal occult blood testing. This was the Hemoccult 2 test in the UK and in Denmark, in Europe. These numbers aren't gigantic, but they're pretty good. Compared to breast cancer screening, for example, this is how breast cancer screening may reduce mortality from breast cancer by 15%, that order of magnitude. These numbers are pretty good. At any rate, they were the first clinical trials. And if we step back and look at the lessons from these clinical trials and quality of evidence, there's some neat things here. One is clinical trials of screening are really difficult to conduct. This is the number 2 cancer killer in the United States. And these studies here took 20 years, involved 250,000 subjects. There was temporary defunding of the U.S. study at one point. They had to figure this into how are we going to do our analysis and so forth. And you've got to think about what's the patience and the timeline of funders and of faculty members who are trying to get promotion and funding and so on and so forth. This is a common cancer. This is a really long time, a lot of money, a lot of subjects to study. And another lesson is, are there designs that are as reliable as clinical trials, but more efficient or as efficient, more efficient than a clinical trial? Because clinical trials are so expensive and cumbersome to do, and we're never going to be able to do enough clinical trials to answer all the questions we've got. This is the holy grail question of clinical epidemiology, of observational research. Are there ways outside of RCTs to generate answers about cause and effect? Doing a clinical trial where you can hold everything equal, understand the biases, avoid biases, it's wonderful and it's beautiful, but it's so hard to do for this kind of problem. That's a separate topic for another day. But here's one example of something that wasn't a clinical trial that's going to get some credibility. There was a sigmoidoscopy case control study published by Joe Selby in 1992 in the New England Journal. Selby's now the head of PCORI, and this was when he was at Kaiser and director of their wonderful research organization of Kaiser in Northern California. And what happened in this case control study was that it shows that sigmoidoscopy screening reduces by about 60% colon cancer deaths within reach of the scope. That's a really big number, but this is a case control study. And what happens in a case control study was you take 261 people who, yes, died of colon cancer within reach of the scope, and you ask how many of them were exposed to sigmoidoscopy. It's sort of backwards thinking in a case control study. We don't have time to go into the details. The answer was 9%. The controls are 868 people who did not die of colon cancer death within reach of the scope, and they had more sigmoidoscopy. So the kind of conclusion you can reach by doing the math for a case control study is that there's a reduction of roughly 60% for colon cancer deaths within reach of the scope. But you got to remember, this case control evidence was considered weak, not acceptable for policymaking. This study, though, was so unusually strong, and I'm going to explain why in a minute, that it actually threatened to give case control studies a good name, or at least a good name in the selected circumstances where certain criteria could be met. And I've put down here below in light type the clinical trial evidence that's going to come 20 years later from the UK, Wendy Atkin, from the NCI, the PLCO study, Rocky Schoen. These are clinical trials that showed roughly the same result, but of course, we didn't have those results in 1992. So let's go back to 92, when the task force had to think about, are we going to accept this? And so this case control study was unusually strong because it was nested in a cohort. It's called the nested case control design. It has an unusual strength because you know that the cases and controls came from the same cohort. We don't have time to go into these details, but this is really important if you're a methodologist trying to think about how strong is this study. The reason for exposure, sigmoidoscopy, was known. They knew at Kaiser if you were getting it for symptoms, because they had a screening program with separate sites, or whether it was for screening. And this is a brilliant thing that they did. They had an internal control group designed by Joe Selby and Noel Weiss. They said, you know, we found mortality reduction from screening on the left. If this is all explained by bias, because the biases in case control studies are hard to even know what might have existed. It's that complicated. They said, well, if bias explains all the results, then there ought to be a mortality reduction on the right. And what they found was, when they compared left versus right, that there was mortality reduction on the left, none on the right. And it was a kind of internal control group that you can do because the colon has a left side and a right side. And all of these things made this case control study a strong thing. And the task force's decision to accept non-clinical trial evidence, which it did in 96, was a major advance in the world of evidence to policy. It's sort of like, you know how when they elect the Pope in the Vatican, that when they burn the ballots, the cardinals, it's either white smoke, we've got a Pope, or black smoke, we don't have a Pope. The world of clinical evidence, my clinical epi colleagues were watching the task force, trying to figure out, are they going to accept a non-randomized controlled clinical trial as evidence? And they did. This was a really big deal in that era. And a lesson from this is we can learn to make weak design stronger. Case control studies are always weaker, but sometimes they might be strong, and the rules of evidence, like that the task force can use, may change. So let's go back to see how the guidelines evolved. Here we are in 96 with the task force saying fecal occult blood testing alone, sigmoidoscopy, fecal occult blood testing alone, that's okay, because we've got clinical trials for that. Sigmoidoscopy, we've got the case control study, so that's okay. But for occult blood testing and sigmoidoscopy together, they said, nope, we don't have any direct evidence of any kind, so it's insufficient. And colonoscopy, there's insufficient there, even though colonoscopy was used when you had a positive occult blood test over here, but there was no direct data. So that's where they were in 96. And so let's now talk about colonoscopy and how evidence of efficacy for it has evolved, because this is really important. This is obviously what we do a lot of in the United States now. The concept of screening colonoscopy has had a dramatic evolution over the last 20 years. In 1992, screening colonoscopy was a lunatic fringe idea that you barely talked about at the GI meetings that we all attended. In 2000, it started becoming a Medicare benefit, and the ACS was petitioning state legislatures to provide coverage. How did this evolution occur, and what are the evidence from that about what's the evidence, how does that get translated into policy, and what's the role of politics? So let's look at how this evolution happened. In 92, there was no controlled studies for any screening, as we saw. In 92, there was the sigmoidoscopy case control study, and then here's the three occult blood testing clinical trials. And then an important study happened in 1993 that's going to be really important in the colon cancer screening world in colonoscopy. It's the National Polyps study published in the New England Journal that says that colon cancer incidence is reduced 76 to 90% by colonoscopy. And here's what happened in this study. The purpose of this study was to assess whether polypectomy reduces colon cancer incidence. And the design was not a clinical trial. This analysis was an observational cohort. The National Polyps study had done a clinical trial with two groups that had gotten colonoscopy and then were enrolled in surveillance. They were testing different surveillance intervals, found no difference between the compared groups, and they said, let's combine both arms into one side of an observational cohort, people receiving colonoscopy. And then we're going to compare that group to historical controls. And that's what this analysis is. It's not a clinical trial. It's an observational cohort with historical controls. And this was where they reported a 76 to 90% reduction in colon cancer incidence. Is this result fair? And the answer depends on the comparison. And I think as a gastroenterologist, this is arguably the single most important paper in the field of gastroenterology in terms of how we practice medicine on a day-to-day basis. And here's what the National Polyps study found. And they found that and what I'm going to describe to you is how the historical control patients differed from the National Polyps study patients at baseline. This is the cumulative incidence of colon cancer going up to 5% at these years of follow-up. And in the black line, this is the people who were observed in the National Polyps study, and this is a low number. It's a low incidence. And then they compared it to the SEER database, an important federal study, the St. Mark's database, because they can follow people from St. Mark's through registries in England, and then a Mayo Clinic Rochester, Minnesota cohort. And the difference between these high incidences and this, that's where the 76 to 90% reduction come from. And the question is this historical control group fair to compare to this? And here's what the potential problem is, which occurred to some extent. We don't know how much. To get into the National Polyps study, to be part of this black line, you had to have a colonoscopy at baseline, because this was to get into the clinical trial, they'd done colonoscopies on everybody, and these are the people who'd had polyps who got followed to see if they got cancer. However, if you had cancer at 0 time, you were excluded from the study. You already had the outcome, they didn't want you, and you were excluded. In contrast, in these groups, which were followed in a passive way, there was no examination at baseline, and people could have had cancer that appeared in later years and became part of the numerator. So these numbers are inflated, and the amount of inflation we don't know, because we don't know the dwell time of cancer. And the National Polyps study investigators tried to do some analyses to account for dwell times of several years. And this is a problem that they knew about, but the point is that these numbers here are likely to be lower, and we really don't know what the dwell times are. And I'm not saying colonoscopy doesn't work. I'm just questioning this 90% number, which is a very typical claim in our field and I think may cause some problems for us in terms of expectations, how we think about modeling and choices among different strategies and so forth. So here's a typical claim. More than 150,000 people are diagnosed. 90% could have been saved if they've gone for screening colonoscopy. The figures are available. So if you ask me how much reduction of colon cancer incidence occurs by colonoscopy, I think a fairer estimate is probably on the order of 50 to 60%. It might be higher, but I think based on the data we've got now, this is probably what we can routinely expect. And here's the rationale. We've now got clinical trials of sigmoidoscopy from 4 countries that show all roughly a 50% reduction on the left. And shouldn't we expect roughly the same kind of reduction on the right? It might even be lower because of flat lesions, serrated polyps, and so on, and the things we don't have time to go into today. But do we think it really ought to be 90%? There are observational studies that get higher numbers, but they're weaker. They're not clinical trials. There are, however, some unresolved things that we don't have time to go into. Does reduction come from the first colonoscopy? Or if you do it repeatedly, for repeat screening or surveillance, if somebody has a polyp, that may contribute too. It may be possible with enough colonoscopies and very good exams and focus on adenoma detection rates and so on, this estimate might be higher. But if we had to estimate right now based on the data we've got, I think you can make a case that it's closer to this than it is to 90%. I don't want to paint this glass as being half empty. This is 50% or 60% is a great number compared to the other things we screen for, except for maybe cervical cancer, where where it's so effective. But compared to breast cancer screening or prostate cancer screening, ovarian cancer screening, we have virtually nothing. This is a really big number. The question is, what's the right number? So let's go back then and see what was happening to the guidelines around that area. Here we are in 1996, and I told you that the National Polyp Study came out in 1993, which didn't convince the task force in 96. But there appeared then in 97 a new organization called the Consortium of GI Societies. It appeared, it got created in those years, and it's going to end up saying, called blood testing, sigmoidoscopy combination, and colonoscopy, that's okay too. And the appearance of the consortium is very important in the field of guidelines making. Why did it appear? Here's who was on the consortium. It's mainly gastroenterologists. Sid Winter was the leader from the National Polyp Study. Most of these people are gastroenterologists, but very notably, there are some really expert clinical epidemiologists and methodologists. Bob Fletcher's an editor of the Annals of Internal Medicine. Fiona Godley's an editor at the BMJ. Cindy Morrow is going to be an editor at the Annals. Steve Wolf is going to be on the U.S. Preventive Services Task Force. This is a very interesting and balanced group with very serious, distant clinical epidemiologists and methodologists. We'll come back to how that organization evolved. But here's what was happening in the mid-1990s. The field of guidelines making was changing. In the 90s, when it all started, guidelines organizations were few and generalist. There was the Preventive Services Task Force. The NCI was in the guidelines making business for a while. Then there was the American Cancer Society. And most of these were dominated by generalists. By the 2010s, there are hundreds of guidelines organizations. Many are subspecialty societies. There are thousands of guidelines, often on the same topic, and they conflict. And they have varying quality. And where this is going to lead to is this. All of these guidelines say they're evidence-based. You're not going to come out and say it's not evidence-based. And the U.S. Congress, around 2008, is going to ask the Institute of Medicine, now the National Academy of Medicine, how do we judge trustworthy? That's a really tough question. It scared the Institute of Medicine committee. They were concerned about trustworthy sounds kind of squishy and hard, but boy, that's what it's about. How do we decide whether we trust them? We're going to get back to that. So here we are in 97. The GI Consortium recommends any of several tests. Colonoscopy is an option. And then this is a really big event. In 2000, in March, Colon Cancer Awareness Month is promoted by Katie Couric, whose husband died at age 42. Jay Monahan of colon cancer She was on the cover of Time magazine in March. She had her colonoscopy done on the Today Show one morning during the week. And then in July 20th was a very major date when the New England Journal published two important articles. Two studies asked, what is found at screening colonoscopy? What do you find if you do it on average risk people? This is a study called Use of Colonoscopy to Screen Asymptomatic Adults. David Lieberman in the VA study. This is another study with a slightly different title, but it's basically the same study by Tom Imperiali. I collaborated with him. Tom had just moved to Indianapolis, and he said he noted that Eli Lilly had done screening colonoscopy on their employees. It was a benefit to being an employee. And he said, what can we learn from this? And we published a number of studies based on the Eli Lilly cohort, and this was the result. The two studies that I just showed you got the same results. In average risk people, the yield of colonoscopy is roughly 1% for colon cancer and 5 to 10% for advanced adenomas. And sigmoidoscopy misses those proximal lesions. This wasn't news in the field. The task force in '96, when it had made its recommendations, sort of work with these kinds of numbers, everybody thought that that was what would be found. These two articles document the obvious. My teacher, Alvin Feinstein at Yale, taught us when we were fellows in the Clinical Scholars Program. He said, you know, when you're doing research, if there's something that's obvious but it hasn't been documented, document it. It's important to show that that's the way the world works. Sometimes it doesn't, but the point is the article that these two articles documented what everybody really did expect. But the New England Journal and the New York Times interpreted this as big news, and this is going to end up having a big impact on Congress and Medicare and the field. And here's what the editorial said in the New England Journal, going to distance the case for true colorectal cancer screening. And the Times reported this on page 1, this new approach. And what had happened was that the editorialist, who is a basic scientist, this editorial doesn't consider outcome or a quantitative benefit of various strategies like a clinical trial did. The reasoning here was that doing an endoscopy exam, a sigmoidoscopy on half the colon, it's like doing mammography of one breast. And that was the reasoning. It was sort of rule of thumb reasoning, no quantitative comparison of strategies, projections of outcomes, which the task force had already been considering, and like would be done in a clinical trial or in a modeling exercise to mimic a clinical trial. So what the Times said was the most commonly recommended test for healthy adults for colon cancer should be replaced by a more extensive procedure. And if you ask, is colonoscopy the preferred test? At the Times said, my answer is going to be no, and I'm going to explain in the next slide. But the lesson here was that this editorial and the news reports that followed had a big impact. Policy doesn't just emerge from evidence. This is going to affect what Congress and others do and how the profession advertises what was done, what ought to be done. So is colonoscopy the preferred test? My answer is no, and here's the rationale for this. The U.S. Preventive Service Task Force and the Institute of Medicine did analyses of 4 cost-effectiveness analyses that incorporated clinical trial data, observational data, the kind of thing that the task force does, and others do, modelers who've been working on this, the important CISNET effort that the NCI has sponsored, that assessed outcomes of different strategies. And what they found was that at any one application, colonoscopy is best because it's very sensitive and it can remove lesions. If you had to do one test in your life, colonoscopy is best. But in a program of screening over time, like colonoscopy every 10 years, colonoscopy can miss new or rapidly growing lesions that could be detected by a less sensitive test, like fecal occult blood testing, done more frequently, because there's more chances to detect something that's new or rapidly growing. So this result that the models found depends on considering first its screening programs over time that we're looking at. It's not just which test, but it's a test over time. And it's the biology. What's the distribution of growth rates? Do cancers that kill us grow rapidly, or do some of them grow rapidly so that we might miss some of them? so that if colon cancers that kill grow rapidly, a program of more frequent but less sensitive tests may be more effective. This is an important conclusion to think about. I hope that it makes some sense intuitively. Quantitatively in these analyses, this is a possibility. It's not like a slam dunk that colonoscopy is preferred, and that's been the stance that the task force has taken multiple times in its recommendations. So let's look a little bit more at how guidelines and quality have become major focuses in the last few years. The consortium evolved, the consortium that I told you about that had birth in 1997. And what I'm going to illustrate here is one example how conflict of interest, just one kind of problem, is handled in the consortium, which is going to become the Multi-Society Task Force, that's GI organizations, and the American College of Radiology, and the American Cancer Society. This is what it's going to be in 2008, compared to the U.S. Preventive Services Task Force. And the way the conflict of interest is handled in the U.S. Preventive Services Task Force is there's separate groups to report the evidence and to assess the evidence compared to who makes the guidelines. This group that makes the guidelines, they use reports that come from a separate group and have input of subspecialists, but it's generalists and methodologists who are supposed to be the impartial judges. That's the idea, who make the guidelines. The subspecialist role is there, but it's limited. With the ACS and Multi-Society Task Force, the consortium of GI and radiology groups, the same group assesses the evidence and makes the guidelines, and the number of generalists and methodologists in the Multi-Society Task Force decreases. Do you remember the consortium I told you about in 1997 that had these four really strong generalist methodologists, general medicine journal editors? In 2003, two of them had disappeared, and in 2008, all of them had disappeared. This ended up being all gastroenterologists and radiologists and some non-methodologists who actually made up some new rules during the course of guidelines making. We'll come back to that. But just focusing on the problem of conflict of interest for a minute, we've got to step back and look at the big picture that professional organizations wear two hats. The interests of clients and patients is one, patients' outcomes. The interests of doctors is a separate one, providers' economic interests. And we need to consider what's the definition of a profession as put forth by Louis Brandeis. He's talking about what's the characteristic of a profession. Why do we treat professionals differently? Should we? He said there's a social contract. Profession stewards a body of knowledge. We generate evidence, science. We convert it into policy. And we put clients' interests before our own. That's the role of a profession, why we get called doctor, why we may get more pay, and so on and so on. That's the definition of a profession, what the profession's role is. The problem with conflict is that interest one, that's the Louis Brandeis definition, and two, interests of people in the profession, they're both legitimate. This really is an important role of professional organizations, but they're different roles, and they conflict. And we, as a profession, have to figure out how to manage them. This is an example of one profession being concerned about its economic interest, and it's a legitimate interest. This is a report from the American Gastroenterological Association Future Trends Committee in 2006 that did a major report called Will Screening Colonoscopy Disappear and Transform Gastroenterology Practice? Threats to Practice and Recommendations to Reduce Their Impact. People have been worried that colonoscopy might disappear because of non-invasive tests, new stool tests, blood tests, and so forth. What's going to happen? And this really is a fair interest for the profession to be concerned about, but it's a different hat than what's the client's interest, and that's first. So let's go back to the 2008 colon cancer screening guidelines and how they differ and why, and what this means for the field of guidelines making. The consortium in 2008, what they said was, at the end of the day, was a structural exam is preferred, like barium enema or colonoscopy or CT colonography. This was interpreted as meaning colonoscopy because the other tests were not very popular. The U.S. Preventive Services Task Force, any of several programs is acceptable. We all get roughly the same answer when we look at the evidence. We try to quantitatively project outcomes and so forth. And then if you look at the process to develop how each of these groups got to these conclusions, the consortium had no pre-stated rules of evidence. They actually made up rules of evidence like prevention is better, early detection is better than prevention. They had one other rule, but they made it up during the course of trying to figure out what the guidelines ought to be. And this is all documented. The U.S. Preventive Services Task Force has its pre-stated rules of evidence. The Russ-Harris essay that I told you about, it's a very elaborate process. Did the consortium assess outcomes of benefit versus harm quantitatively? No, they didn't. The task force does, with modeling and other exercises. And is conflict of interest managed? No, it wasn't here. Yes, it was here. There were other kinds of differences, but the point is the Institute of Medicine is going to use these comparisons as an example of differences in quality of guidelines making. So around 2008, and it was before the colon cancer screening guidelines, Congress was asking the Institute of Medicine, how do we tell if a guideline is trustworthy? Because there were so many guidelines and they may conflict. This is the report that they produced, published in 2011. And this is a list of the kinds of standards that they produced. And the kinds of standards include things like transparent process, conflict of interest. It's not just that you declare it, but here are some suggestions about how to manage it. Evidence quality and recommendation strength. What's the reasoning behind each recommendation? Summarize the evidence for benefits and harms. Look at this in a quantitative way. Characterize the quality and quantity of the relevant evidence and so forth. And there's other things here, and there's lots of detail, of course, in the report. But here's the problem that the IOM left us with. And I worked with this committee and provided some material for them and spoke at one of their meetings. They had a really tough task. And the standards that they developed are really hard to apply. The problem is that what's listed over here, these are broad principles. There's no scale that they produce that has variables. How do we, the variable is management of conflict of interest. Categories. How do we judge good, fair, poor, and criteria for these? And the bottom line is that if you're faced with a specific guideline, you're reading it, you're trying to judge whether it's trustworthy, there are principles over here, but there's no specific way to figure out, is it trustworthy or not? Is there a fatal flaw here? How big is any potential problem that it's got? How do we make an assessment about how trustworthy it is? Now, this is a really, really, really hard thing. And the Institute of Medicine did great work to get as far as it did here, but it didn't get to the point where you can readily apply what these broad standards are. There's other steps still for the profession to make. So getting back now to the last few slides, let's talk a little bit about what's happening in 2016. And again, this is a really neat topic that we have only a few moments to describe, but set the stage for what the task force in the field need to do in the future. I want to say a few words about the 2016 U.S. Preventive Service Task Force colon cancer screening guideline that came out in June 23rd, 2016, with multiple articles in JAMA. And the screening guideline evolved dramatically from its draft form to its final form. And it says there's some interesting and important and not clear yet things going on in the field of guidelines making with the task force, which has been the leader. And here's what happened. In the draft version of October 2015, published not in JAMA but is online, you can find reference to it in the JAMA articles, the draft version recommended 3 tests: fecal immunochemical testing, a stool blood test every year, fecal occult blood testing plus sigmoidoscopy or colonoscopy. Those were the 3 strategies. And there were 2 alternative tests, CT colonography and a combined FIT, fecal immunochemical test plus DNA test of the stool. These were called alternative tests. This was a new term. It was a new label. And it was unclear what this meant. And because the task force was designated in the Affordable Care Act of 2010 that its recommendations that get an A or a B, they have to be paid for. by payers. These strategies were considered, yep, they're paid for, but these alternatives fell in some category that payers and test developers couldn't understand. It was a new category, and it wasn't really explained by the task force in their draft version. And these recommendations were based on modeling results in something called an efficient frontier, which is a tight quantitative criterion looking at the amount of benefit per effort colonoscopy, per number of colonoscopies done for each strategy. The colonoscopy is not, the task force is not allowed to consider cost. Looking at the efficient frontier in modeling was one of the bases for getting to this: 3 tests or strategies recommended, 2 in a new category. But the task force asked for public comment, and they got a lot on this, and they always ask for public comment. And between October and June, the recommendation changed to this. There were in June 7 tests or strategies, including these 3, these 2 alternative plus 2 others, that may be discussed in shared decision-making. And the task force didn't make any distinctions between them or any firm distinctions between them. These all appear to be acceptable in what the task force recommended, and it provided lots of quantitative data. And it said, we've based this on brand new considerations or considerations that we've thought about in the past, but are making more important now, like compliance. The best test is the one that gets done. People may not always comply with fecal immunochemical testing every year, for example, and quality. These are very important things. But the point is, these are new kinds of rules. And the challenges then in 2016 are for the field and for the task force is in the field, we're trying to understand what are the reasons for this change, task force, you're the leader, and what's the implications for the future? In other words, where is the bar for having an acceptable test? And this is important. It's important, I think, for the task force, which has been historically the leader of the field of evidence-based medicine. It's important if you're a test developer, you want to know where's the goalposts. One of the things that happened in 2015 in October when, the fecal immunochemical test combined with DNA wasn't approved because it had gotten some strong results in the New England Journal and so forth, and it looked like it would at least be considered, and it had been approved by the FDA, it looked like it would be considered one of the acceptable tests, even if economically it might or might not be competitive, and so on and so forth. But at least in terms of performance, what happened was that other observers, test developers, big pharma companies, I have heard, looked at this and said, you know, we're going to stop investing in the U.S. market for tests that we have because the bar is too high and it's unpredictable. And the point here, and we're going to go to China and other places and invest there. And the point is that a bar is needed first just for general principle. And second, that people need to know what it is if you're going to make investments of hundreds of millions of dollars in developing tests. This is something the task force can do, and it should do. The task force has been the leader. These are legitimate things to consider, and the task force needs all of our support to try to incorporate these things, all of which are fair. So these are the things that we've talked about today, and this last slide has some summary points that may be the basis for discussion. Again, this subject is very big, and we haven't had time to discuss lots of things we could. The summary points are that guidelines don't emerge from evidence. Guidelines making is a human process. Quality and trustworthiness of guidelines may vary. Second, guidelines making affects practice. It's the targets for what we aim for. It affects quality judgment of practice and payment. And it affects patient outcomes. And guidelines making, I think, is the highest calling of our profession to go from evidence to what's right for patients. I think the profession's role is to do the science, which is hard enough to do, given clinical trials, observational data, how do we integrate this, to generate evidence where we can project patient outcomes of benefit versus harm. This is a gigantic, difficult task. I suggest, and others have suggested very eloquently in JAMA, and I've provided a list of references to Rationale that you'll be able to get, where to draw the line is arguably a separate and political process. Our job should be, like the CIA, in providing evidence to the policymakers. We're supposed to provide the unvarnished, our best estimate of what is the truth and what's really going on. Then where to draw the line and what to pay for, that's why we've got governments. That's why we've got payor organizations, and we may risk corrupting the science if we combine the science process and the political process. And the last point is that we need our best organizations, like the task force, which I have been a fan of for a long time, because I've grown up in the era of when evidence-based medicine grew up. The task force has had such an important role. We need our best organizations to be insulated from political pressures to do the best science, which is the foundation, and to lead the field of evidence-based medicine. Again, a big subject. These are selected topics. Thank you for your attention in cyberspace. And now, Carrie, I'm turning it back over to you. Are you there?
Yes. Yeah, thank you. An excellent presentation. We do have a couple of questions. So in no particular order, I'm going to start by asking you to go back to the issue that you had brought up about how there really seems to be a proliferation of guidelines. There are multiple guidelines for colon cancer screening, and we see this in other areas of cancer screening as well as in other areas of medicine. So how does one go about trying to harmonize guidelines, or is that even possible when you have guidelines that disagree? I mean, this is a situation where it can be really confusing for people in clinical practice. And can you comment on whether there are any examples of where obtaining some kind of consensus among guidelines makers or harmonizing guidelines has actually been done successfully?
You raise a really important question, and I don't think that harmonize should be our goal. I think our first goal should be to have measures to understand the quality of the different guidelines. First, so we can understand what the quality is, and some really may be better than others. And if it's a low-quality guideline, I'm less concerned about trying to harmonize with them. So I think we need to develop the IOM principles more into standards that we can actually apply. Second, I think it's I think one of the problems with guidelines making is that when the guidelines differ, it is very rare that the guidelines writers make any effort in their discussion section to explain, here is why we differ from somebody else. Difference is okay. I don't think we necessarily have to have harmonization. Is it because we're looking at different evidence? We're assembling it in different ways, or we see the evidence the same way, but we're making some different call about how much cancer we want to prevent, or how much we're willing to pay, or how many side effects or harms we're willing to take. And I think it is fair for different organizations to reach different conclusions, but because we have low expectations for what happens in guidelines, we don't have real peer review of guidelines. They're basically pass-throughs for professional journals where they don't get serious peer review. It's just decrees by committees. And I think, for example, the ACS and the U.S. Preventive Services Task Force have historically had differences, and important ones, for colon cancer, for breast cancer, and for prostate cancer. And I think it could be okay to have differences as long as the groups explain. I think it's a bad idea to get people in a room and to try to reach consensus, because that just makes it too much of a political process. So I'm not troubled that much by some difference. I think we would benefit professionally and in terms of outcomes if we could understand more and make more transparent, like the IOM says, what's the process, what's the reasons for differences, and we could even live with differences too. It's not necessarily bad to have it. Right now, we may not understand why there's differences because processes aren't transparent enough and we can't understand quality. I'd fix those first. Thank you for letting me do that long-winded answer.
This is Rationale. So we have a question, I guess it's kind of a dilemma. Many guidelines are complex enough they are difficult to keep clear in the clinician's head and difficult to discuss and implement in the typical short office visits. Clinical decision support software can potentially help, but guidelines are sufficiently wishy-washy, age range, may use, etc., to make encoding them in software managed algorithms difficult. Do you have any comments on how we can overcome this?
I Well, I have some suggestions that I think we need a more concerted effort. We may eventually want to separate out prevention and screening guidelines from routine clinical care, and have separate facilities or efforts or units where things can be discussed in enough detail and with material that we can give to patients. There's Mike Barry's society, and I'm blocking on the name, which and I'm embarrassed by that, which makes a big effort for shared decision for providing and developing shared decision-making tools for patients. I think we need more effort in those areas. Figuring out logistically how actually to implement them will be a challenge, but it's doable. But I think we need many more patient education materials, and to acknowledge that if we really want to have honest shared decision-making with patients about complicated things like prostate cancer screening, where there can be major side effects, breast cancer screening, for colonoscopy, for colon cancer screening, it's mainly effort and some inconvenience. But we need to provide patients with the kind of information that they can use to make decisions. That's complicated, and it can't be done in a simple visit with a general internist. We may need to have whole separate facilities and online tools. It's an area that needs to be developed. It's important.
We have one last question, and then we're going to need to wrap up the seminar. But given the current focus on individualized risk assessment and also the rapidly evolving field of precision medicine, how do you see these affecting the guideline development process in cancer screening, and especially the work of a group like the U.S. Preventive Services Task Force, which is typically producing guidelines for a general asymptomatic population? It seems like the individualized risk assessment and precision medicine is going to make this much more complicated.
Yep. First, just about the task force and what it does, it's interesting that in the colon cancer screening guidelines, they deliberately didn't talk about family history and whether those people should be treated differently. They referred to other guidelines makers' suggestions for what ought to be done with people with a positive family history. And I'm not talking about a cancer syndrome like adenomatous polyposis coli or Lynch syndrome, just regular family history. And that's sort of what precision medicine is doing now. We're using phenotype like family history. I think it would be useful for the task force to devote more effort to different risk subgroups like positive family history for colon cancer. It's asking them to do more work, and they've got lots of work to do. But it's interesting that the task force doesn't do that. With regard to the other issue that you raised about whether new approaches to precision medicine are going to provide benefit here, I am hopeful, but I'm skeptical. The idea of precision medicine and genetic and genomic markers in colon cancer screening is not a new one. People have been working for years with circulating DNA, with DNA in the stool, with RNA, with proteomics, and so forth. And this is just a really hard field to figure out the biology. It is a very hard field to do good research, and we understand so little of what Mother Nature is doing in cancer that the list of candidates is just gigantic. So it's not a brand new field, and I'm hopeful, but I'm not holding my breath in this field. I think precision medicine, in contrast, is likely to have much more usefulness in cancer treatment, where we can look at the genotypes of individual tumors and where we can focus efforts and targeted drugs that even may have side effects in those issues of treatment as well. So I'm hopeful, but it's not a brand new area, and the research is very hard to do. In the meantime, though, we've got some awfully good screening tests that work in average risk people, and figuring out how to manage them is an important current challenge.
Thank you. Thank you, Dr. Ranselhoff, for all the useful information. And thank you to everyone who participated in today's webinar. On the Medicine Mind the Gap website, prevention.nih.gov/mind-the-gap, you will find several resources for this talk, including the slides, references, and a link to complete an evaluation. Your feedback is very important to us as we plan future sessions. Thank you again for your time, and we hope you will join us for the next session in our disease screening series, Guidelines for Cancer Screening in Children, which will be presented by Dr. David Grossman on October 20th at 11 o'clock a.m. Thank you.